Okay.
Good evening, everyone. Welcome once again. I'm Dr. Sayyida Rukshida. I have the honor of being the Honorable General Secretary of Indian Association of Biological Psychiatry. Every Friday, every first Friday of every month, we have a CME. It's a webinar series that we started because of the demands of the pandemic, and we realized a lot of our psychiatrists and SRs and JRs are kind of missing out on a lot of hands-on information. So the first Friday CME series, it's a curated CME, it's open access, it's an education series. Today it happens to be supported by Alchem. We have wonderful topics and wonderful speakers and experts in their fields on a wide array of topics of biological psychiatry. And today, in keeping with the run-up of to International Women's Mental Day, Women's Day, we have a very special session with us with a renowned expert in her field herself. At this point, it's an honor to welcome a senior member, a former FMB member of our IABP, Dr. Anukant Mittal, who's also currently the president of Indian Association of Private Psychiatry. He's a senior psychiatrist from Mumbai, and I think all of us know him and have associated with him, and he's helped, I think, a whole lot of us out there. So Dr. Anukant Mittal, sir, please share some welcoming remarks.
I would like to thank you all for inviting me, because I may probably be the only male member on the other side, but I believe a sentence that a lot of juniors and JRs
Sir is joining us from his chambers in a hospital, so he has questionable Wi-Fi and internet connection. I hope he can join us soon again, but with his, I'm sure, erudite remarks that we have missed out on, it's an honor again. Yes, we have him back.
I felt that, when I went a long time ago as a DNP examiner, I studied for 6 weeks, and my wife asked me if I was going to give the exam or take the exam. And I told her the DNB students and MD students are the most well-read. So if I ask him a question, whether he's trying to fool me, because he knows that I don't know anything about it, I should know at least कि वो टोपी पहना रहा है, क्या टोपी पहना रहा है वो नहीं पता चले, कम से कम पता तो चलना चाहिए. उस तरह से I believe that the JRs and the SRs are currently the most well-read. It is we seniors above 40s who need to be taught, because we've got into the mindset कि patient acute psychosis में आया तो इसको sarinase Finargan ठोक के बांध के रख दो बेड पे, 4-5 दिन तक जब तक शांत नहीं हो जाए इंजेक्शन देते रहो, उसके बाद देखेंगे. ECT के लिए पोस्ट करो. We work with preset notions and preset training practices that we've had to talk about third messenger systems and molecular levels and genetic expressions and all that. I remember 15 years ago when we were just in the nascent stage of biological psychiatry, we used to call a gentleman called Dr. Suresh Sundaram from Melbourne. And when he used to talk about first and third messenger systems and genetic coding and all that, 99% of the audience used to. So then we had to ask him to water it down and go step by step. So I think, yes, we need to learn more. And today, of course, a lot of, I would call them young. Jyoti, yes, I'm going to call you young. A lot of people there, they read more. They are more knowledgeable. And I guess we need to learn a lot more from them. And I think these webinars play a very important role, not for the JRs, but for people like us who have passed 10 years ago or 15 years ago, and who have not seen the recent releases. So thank you very much. And I really welcome Dr. Rajni, Dr. Sonia, Dr. Jyoti, everybody else. I'm so happy to see that what we envisaged in 2014 in Seoul, 2004 in Seoul, in Korea, where I presented a paper on biological psychiatry. And that is where we formed the Indian Association of Biological Psychiatry. We have reached such a stage, and I'm proud of you. Thank you very much. Thank you very much. Yeah. Please continue.
Thank you so much for your remarks, sir, and yours. Getting on with the session today, I'm excited and it's a pleasure to invite the first chair, Dr. Jyoti Shetty. She's the HOD at Bharatiya at Pune. She's a very close personal friend and my personal library. Anything that I want, I don't even bother looking it up. I just tell her and she gives me references. So you clearly know that, one would assume there's nepotism at play, but trust me, she is also an authority on the subject as well, authoring a lot of articles and chapters and presentations as well. And she's going to be an excellent chair today. And co-chairing her today is another dear friend, Dr. Nishan Goyal. He's the associate professor at CIP because we thought, we have a speaker from CIP, so maybe it would make a good gang for us. And he's also the executive council member of Indian Association of Biological Psychiatry. And just before we started off, all of us were full of praises for him. And I'm sure, when he's chairing the session, all of us all will know that all of those words were far less to describe him. So at this point, it's an honor and a pleasure to welcome our chairs, Dr. Jyoti Shetty and Dr. Nishan Goyal. And the session is over to you guys. Take it away.
Okay. Yeah. Good evening, everyone, and thank you, the IABP and Dr. Ruksheda, for inviting me here. I think without further ado, I would like to introduce our speaker today, Dr. Sonia Pariyal, who's the chairperson of the Perinatal Psychiatry Task Force of the IPS. And I know this topic that is there, that is psychopharmacology in perinatal period. I mean, not only is the area and the topic a labor of love for her, but she also does very labor intensive presentations, pun intended. And without further ado, I welcome you, ma'am. Please continue with your presentation.
Thank you. Thank you, Jyoti. And also, I would like to thank the Indian Association of Biological Psychiatry for having given me this opportunity. And I think I'm feeling a bit overwhelmed because I must say I'm no great authority in perinatal, but yes, it's an area of interest. And whatever I have learned, I would love to share it with you all. And I would love to have a good interaction with you guys. And like Sir said, a lot of learning to do. And I hope this session will be meaningful for all of us. I'm glad to have Nishant, because I know he's my soft corner from CIP, and I hope he will also share his views, and I would also get to learn from you guys. So let's start today with some basic learnings, because Rukshida wanted some essential learnings. So I thought, today's topic, I will divide it in such a way that if I assume there's some youngsters, there's some seniors, so I thought we can divide it into two parts. One initial part would be some basics about pharmacokinetics, about each of our psychotropic drugs. And then we could go on about a little bit about the general guidelines that we need to follow. So we have around 40 minutes to 45 minutes. I have a problem of verbal diarrhea, so please forgive me if I talk too much. And you can interrupt me in between if you feel so. So let's start the presentation. I hope my screen, is it being shared?
No, ma'am.
Yeah, can my slides visible now?
Your screen is starting to share. It will come up in a second, I think. Yes, we are good.
It's there? Okay. So like we said, it's about certain essential learnings. If you look at perinatal mental illness, with the recent policy changes all over the world and the improved treatment and rehabilitation practices, more of our women with mental illnesses are carrying out parenting roles. And we have to realize that perinatal mental illnesses are one of the most commonest illnesses in the perinatal period. And nearly 1/3 of our patients experience it for the first time during pregnancy. You see, previously we used to think that pregnancy is protective for mental illness, but now we very well know it's not so. The changing scenario, we know that the amount of stress that women are facing, that you are seeing an increased onset of disorder. Similarly, patients with severe psychiatric illnesses, they too are getting pregnant. And what is more worrying in this group is that most of these pregnancies are unplanned. As we know, that nearly 50% of pregnancies are unplanned, especially in India. And most of them are unwanted as well in severe mental illness. So that becomes very, very challenging to manage. And keeping this in view, we would discuss today with the point that, you see, previously the focus used to be that the drugs are very teratogenic, they are very harmful. But now in the last decade, we have found that the illness itself is a neurotoxic condition, and it can have a lot of impact, not just on the mother, but on the fetus as well. And we as psychiatrists are realizing that more and more in the last 10 years. So, but how do we communicate this aspect to our clients is equally important, because see, even if a patient is coming from rural area, they are very well aware that drugs are harmful, especially during pregnancy, and they're not breastfeed also. But how do we communicate that if you don't treat the illness, it's going to have even an equal amount of worse impact? And so I would try to focus our talk today, keeping both these aspects in mind. So if you stop medications, we know it can cause a recurrence or a subsequent relapse. And in severe cases, it can even lead to suicide or infanticide. And like it is one of the leading causes of mortality, especially in the postpartum period. We know that suicide and infanticide can occur. So it's keeping this in view that, perinatal has become a specialty in it on its own to identify these disorders early and treat them in the right time to give better outcomes to the pregnancy. As I had mentioned, that we were attributing all the harm to our drugs, but we didn't know that the maternal mental illness itself can cause abortions. It can be responsible for abortions, for prematurity, low birth weight, and you need intensive care admissions and higher risk, chances of having a cesarean delivery in the women who are mentally ill. I think this is the main crux of the message that should go to all our youngsters, how we communicate this aspect to our clients so that they make better decisions when they are asked to take treatment. Now, of course, we know it's challenging because pharmacotherapy of these disorders is complicated by the concerns of the risk of the drugs to the pregnant women and to the breastfeeding infant, because, we still don't know what is the long-term impact of our medications on the infant. Does it cause a delay in language development? Does it cause a difference in IQ? And does it cause autism? The drug has been attributed to cause so many harmful effects. And the research has been quite flawed in this because we didn't compare apples to apples, in the sense that what we did was we were comparing data previously of normal population with pregnant women. We were not comparing, say, depressed women on treatment and depressed women without treatment. So the research earlier was quite flawed. And in the 10 years, the good news is that it has been found that it was these confounding factors which were more responsible rather than our drugs. So we have to identify all these factors when we do research in this area. And I hope that more and more people will get interested, and we would be able to have more birth registries in India to work to identify what are the confounding factors which are coming into play, and that it's not just the drug which is responsible. So it is a challenge how you balance the risk and the benefit. Hope with today's talk, we'll get some ideas, some knowledge of basics to consider while treating. So let me start with some basic pharmacokinetics. That during pregnancy, there are a lot of dynamic changes in the physiology which can affect pharmacokinetic parameters absorption, distribution, metabolism, and elimination of psychotropics, especially when interacting with the changed hormonal milieu. We know that the changing levels of progesterone and estrogen during pregnancy, they can affect the pharmacokinetics of most of our drugs. As we know that the cardiovascular system, you have a lot of changes. You see that the heart rate and stroke volume increases in pregnancy, leading to nearly a 30 to 50% increase in maternal cardiac output. And a 75% of it occurs by the end of the first trimester. And it is differential that a lot of uterine blood flow is increased as the plasma volume and the heart has to work much harder and in the last trimester. In the renal system, it is found that the GFR and the renal blood flow is increased by nearly 50% as early as 14 weeks of pregnancy. And this increase in GFR leads to decreased serum concentrations of our medications. And the increase in renal clearance can have a significant impact in the elimination rates of the renally cleared medications. And there's also a great amount of water and sodium retention, so much so that by last trimester, the body water is increased to around 6 to 8 liters. So the volume of distribution of our drugs increases quite a lot. Then we also observe a delayed gastric emptying and a prolonged small bowel transit. And this is due to the rise in the progesterone and the estrogen. We know that progesterone can slow the gastric emptying. And there is a decrease in the Cmax and increase in the Tmax levels of our medications. And because if you're taking it as single dose and you want it to act faster, the desired level that you want because of the changes in the gastric motility. Also, the drug absorption is decreased due to nausea and vomiting commonly seen during pregnancy. We also see that a lot of changes in our drug metabolizing enzymes that happen in pregnancy. You see the phase 1 enzymes, the enzymes involved in the phase 1 metabolism, that's the process of reduction, oxidation, and hydrolysis, and the phase 2, all these enzymes are dysregulated rather, they become more active during pregnancy, like the cytochrome P450, which plays a key role in the phase 1 metabolism, and the UGT in the phase 2 metabolism. They're all modulated by sex hormones during this gestation period. And these changes lead to increased metabolism of our psychotropic drugs. There's another factor which comes into play, and that is that the maternal metabolic phenotypes of our are also varying. You know, some mothers may be poor metabolizers, some may be intermediate, some might be extensive, and some might be ultra rapid. So there can be so much of a wide variation in the ability to metabolize a drug. So every patient is different, you know. Hence, the final result, what is the drug level that you can be achieved, depends on a lot on the changes that have occurred in the metabolizing capacity during the pregnancy period. Am I audible? Can you hear me?
You are audible, ma'am. You are audible, clearly audible.
So the modified, now what are the changes that we see in the fetus? The modified maternal drug pharmacokinetics in combination with the placental transfer potential can also affect the fetal drug exposure. Now, there are 3 factors which are very important for a drug's placental transfer rate. One is the lipophilicity of the drug, the pH gradient across the placenta, and the drug's protein binding characteristics. Now, most of our psychotropic drugs are more lipophilic, and the drug protein characteristics, they vary. So the drugs which are highly protein bound, they go less to the fetus. So the exposure to the fetus depends on all these 3 factors. Like I mentioned, that these lipophilic drugs, they can cross the placental barrier much easily, and they reach and distribute to the fetal compartment with varying transfer rates. And also they determine are the drug transporters. So if there is an ability to bind to these drugs transporters higher of particular drugs, they might end up being more safer, like say sertraline. Similarly, the permeability of the fetal blood barrier is related, and the immature central nervous system generally gets more exposed to these drug effects. So the more permeable is the fetal brain barrier, the more, and the immature central nervous system, the more sensitive it will be to the drug side effects because of the increased transfer to the fetal brain. So that's the point of worry, because our drugs If they go more, and some of them are highly permeable, we don't know what is the level of impact they have had on the fetal brain. The hepatic mechanisms are also not mature of the fetus to handle these drugs. We know that a fetus has reduced rate of drug metabolism, and hence there is a chance of increased drug accumulation in the fetal compartments of our drugs. And in the late stages of pregnancy, especially in the first 3 weeks, the metabolic capacity is relatively low and to handle the medications which are given to the mother. I'll just take a 2-second slide because I'm not getting my slides a bit clearer. Coming on to individual drugs. Some benzodiazepines have long half-lives, and they may lead to more drug accumulation. For example, diazepam. It may accumulate more in both the maternal and fetal compartments. So you have to be careful when you're using these drugs because of their longer half-lives. Whereas the ones which have shorter half-life, the chances and which have no metabolites, they might be safer, like say lorazepam. Now coming on to pharmacokinetics of antidepressants, what has been noticed that due to increased metabolism of drugs in pregnancy, there is reduced levels of drugs of these antidepressants. Some antidepressants have active metabolites, and due to the presence of active metabolites, the chances are that the drug might last, its effect might last much longer, and the impact may be more on the fetus. Coming on to antipsychotics, what are the changes in pharmacokinetics? Now, what has been studied is of late is that olanzapine and haloperidol, they have the highest placental passage ratio, whereas risperidone and quetiapine have been found to have lesser placental passage ratio. Maybe that's why, quetiapine is becoming a popular drug because of its least placental passage. The exposure to the drug to the fetus will be much lesser to quetiapine. So that's an interesting fact that we should remember when we are selecting our psychotropics. This affinity to plasma proteins, that is a P-glycoprotein affinity, is a crucial factor which affects our psychotropic drugs like quetiapine and risperidone. Similarly, what also observed is quetiapine is metabolized primarily by these CYP3A4, which is very much induced in pregnancy. And that leads to lower exposure to the fetus. Lithium is also an interesting molecule. When you use lithium in pregnancy, effects, previously it was thought that it should not be used at all. In fact, all the mood stabilizers we know, lithium, valproate, carbamazepine, they all cross the placenta quite easily. But lithium was one molecule which was implicated highly with teratogenic effects and not used because of the fear of the fetal anomalies that it could cause. But of late, we have found that lithium is not that unsafe a molecule. And though it has a narrow therapeutic index, but it does have a very good effect on the suicide tendency and the bipolar disorder as its best mood stabilizer. So we all should be aware that lithium clearance increases by 50% in pregnancy due to increased renal function. Hence, the serum lithium level decreases quite a lot during the pregnancy. And you might have to increase the level of lithium to get its desired effect. And chances of relapse will be much more during pregnancy if the mother was on lithium if you don't adjust the doses. Similarly, in the postpartum period, the lithium clearance rapidly returns to baseline. And hence, you have to reduce the dose immediately. In fact, during labor, we even have to stop it so that the level doesn't take toxic levels. So, it's quite challenging when you're using lithium. We have to be aware of these pharmacokinetic changes that happen during pregnancy. We don't know much about pharmacokinetics of lactation, but the two main parameters that have been understood about lactation is that the drugs, they diffuse across the placenta by diffusion. Now, when it comes to breast milk, how do you measure? You can't measure the exposure to an infant through the infant plasma level because it might not be ethical. But we can study the level by measuring what is the maternal plasma level and what is the level of the drug in the breast milk. So there were two parameters that were used. One was the milk plasma ratio, which means that if it is less than 1, there is negligible excretion to the milk and the drug is considered safer. And if it is higher than 1, it means there can be significant exposure. But this is not a very, what should I say, well-validated parameter, but it just gives you some clue. The other parameter which is more commonly used, again, it is not foolproof, that is the relative infant dose. It has been used as a key parameter by many pharmacologists to assess the impact of the dosage to the infant during breastfeeding. And this RID, it is basically an infant weighted adjusted dose ratio. It is a proportion of the maternal level and the breast milk level. And you assume that 150 ml per kg body weight, the milk is going to be taken by the infant. And so there is an adjustment of the maternal weight, maternal dose and the placenta depending upon the dosage of the drug. If RID is below 2, it is thought that the infant exposure is minimal. If it is 2 to 5, then it is small. Moderate, it is 5 to 10, and high when it is above 10. So if the RID is less than 10, it is considered that breastfeeding is safe. Now, there have been a lot of literature. I've just summarized in this through various collections, the relative infant doses of the various drugs that we use. And what is the interesting and the promising part and good news for us is that most of our drugs in breastfeeding are safe. If you can see, the RID, except for lithium, all are less than 10%. So that means that they're compatible with breastfeeding. Even if you see the milk plasma ratio also, most of them is less than 1. There might be a lot of variability in the literature about the availability, but major message that goes across is that our drugs are relatively safe in breastfeeding. The only two drugs that you need to be taking a little bit of precaution is lithium and clozapine. It is better not to use them during breastfeeding. Rather, you can stop breastfeeding. And if you want to continue with lithium in the postpartum period, better that we advise the mother not to breastfeed the child. It was not possible all the time to, take the direct infant plasma levels. But even then, there are some reports that they have given permission if a mother is on lithium and she wants to feed, that you can measure the infant plasma level. But in the Indian scenario, it's not very practical. So if you're using lithium in breastfeeding, better to advise the mother not to feed and rather treat the condition if it is very severe. And same again with clozapine, you have to be careful. You know the impact that it can cause agranulocytosis, theoretical risk is there. So again, there is an ethical issue. So except for these two drugs, the good news is that all our antipsychotics, benzodiazepines, all are relatively safe. Now, let's just touch briefly on a little bit of basic embryology that we all should know to find out if our drugs, how teratogenic they are and when they can be. Because we know that most of our pregnancies are unplanned. And by the time the patient comes to us, exposure has already occurred in many of our cases of the teratogenic molecule. And that's why we need to know what is called as the all or none period. The time after conception to implantation is 8 to 10 days, which implies that exposure to any harmful agent will either lead to spontaneous abortion or intact survival. And in the embryonic period, that is starts from implantation and lasts up to 54 to 60 days after conception. That is the time when maximum organogenesis is taking place. So this is a very, very sensitive period where our drugs can cause teratogenic results and it can lead to structural malformations. So the first 60 days are most harmful period. And that's why we say that in the first trimester, try as much as possible to avoid the psychotropic drugs, especially who have a known teratogenic potential. And then continues. So if you till birth, the teratogenic exposure during this period usually leads to disruption to the size of the organs. So basic embryology, if we are aware, we'll be able to, so if exposure has already occurred and and you decide that no, you should stop the medication, maybe it's not very sensible because already exposure has occurred. And so you'll have to go for the scans and the echocardiography to see what has happened if there are septal defects or any other malformations due to our drugs. And now, the most of the structural territoric molecules in the first trimester, the ones that we use are implicated that have been paroxetine, lithium, valproic acid, carbamazepine, and some reports about venlafaxine, but I think venlafaxine is a little tricky. It's just few reports have been mentioned. Even paroxetine, in fact, larger studies have questioned now the 2.5 times the risk of heart defect risk. So FDA had given a warning that don't use paroxetine, but now the current research which studied the confounding variables, these variables were detected and they were studied. It was found that maybe it was the illness itself and these confounding variables which were responsible, not paroxetine in itself. So maybe even now paroxetine is much safer than it was thought to be. Same way for lithium, the cardiac malformations, the risk initially was thought to be 400 times higher, but now it is found, no, it's not that high. Then of course, during exposure, there is a chance that our drugs can cause drug intoxication or drug withdrawals, especially benzodiazepines. When they're used in higher doses, they can cause sedation and they can be responsible for respiratory depression. So the fetus can get more sedated if the mother is exposed to a higher dose of drugs. And also the fetus infant can experience withdrawal when these drugs are, when the baby is born, the withdrawal can be severe with benzodiazepine. So we have to be aware of the withdrawal possibility. We should try to avoid the floppy baby syndrome. Now, with SSRIs, withdrawal symptoms have been noticed, especially in 30%, which are relatively mild. The worrying study was, implication was more with PPH, that is persistent pulmonary hypertension, which was more seen when the drug is used in the third trimester. And SSRIs have been implicated. Compared to SNRIs, more studies have been there with SSRIs, which have said that they can cause PPH. So when you're doubting an anomaly, do go for an anomaly scans and fetal echocardiography. You can do it at level 1 ultrasound. They say we can use it at 12 weeks, studying the nuchal translucency. And then you can go at 20 weeks high resolution one. And for fetal echocardiography, you can use for lithium, for Epstein's anomaly. You can get asked for it at 18 weeks. 16 to 18 weeks is the ideal time to do it. So now coming on to choosing drugs, what are the basic principles that all of us should keep in mind when we are in our clinical practice and we may have to use these drugs with our clients? If you say every lady, every girl is a potential mother. So if the earlier we start applying this principle, the better it would be. It is advisable that all ladies of childbearing age, when they come to us, we should educate them about planned pregnancy. We should educate them about the contraceptive measures that they can use, and of course, a healthy lifestyle, because we know that many of our patients, they lead very unhealthy lifestyles, due to which they can have nutritional deficiencies, they can be obese, they can have vitamin D deficiency. So the nutrition part, the weight part, all these should be addressed much earlier to have a healthy baby. And we can plan and avoid medications with known territory in advance. Like we can avoid valproate and carbamazepine usage right from the beginning itself. And this applies to all our psychotropic drugs. So, but if the mental illness is newly diagnosed, now, you know, it's been diagnosed the first time, so there was no chance of your planning and she has come to you, then it is better try to avoid all drugs in the first trimester, unless the risk, the benefits, they outweigh the risk. That means if the illness is mild, you can avoid the medication part. But if you feel no, the intensity of the illness is severe, then you try to use an established drug with the lowest effective dose. Now, if woman taking psychotropic drug is planning pregnancy, consideration should be given to discontinuing treatment if there is a risk of relapse. Now, if you know very well that when we discontinue treatment, many times patient is not willing, the risk of relapse can be much more harmful. So it is advisable that we explain this risk in simple terms to the patient and the family so that they make an informed decision. If they feel, yes, no, I don't want to take even one chance risk of this drug. If it can cause, say, autism or it can cause PPH, I don't want to take this chance at all. Then you are forced to discontinue because we have to respect our client's opinion. So discontinuation, many a times we do have to discontinue because of our client. And at times when the risk is very severe and the relapse is very, very high, patient might want that you switch to a low risk drug. But we know that switching can increase the risk of relapse. So it is advisable that we explain this risk to the client as well, and not just tell them that we are changing the drug. We are, especially in Indian practice, we expect that the patient should just follow what we say. But in the new scenario where patients are getting more and more Google, they have access to Google research and they're reading materials. So it is advisable to explain to them that what is the risk involved if she relapses. You can have suicide, you can, if the illness increases in severity. So don't discontinue the drug. And the harmful effects of discontinuing due to the illness can be as severe as you're thinking due to the drug. So this explanation, how we communicate this information, is very important. Now, if women taking psychotropic drugs discovers that she is pregnant, many a times she herself abruptly discontinues. And at times we also, when we are not, well equipped with knowledge about our own skills in perinatal area, we make the knee-jerk decision of stopping the drug, and that is quite unwise because it can lead to further relapse. So try to be calm in your decision making at that time. Consider remaining with the current medication rather than switching. But if she is on a known teratogenic drug like valproate, definitely you should stop it, because valproate is one drug which has in fact been banned in certain European countries like France, simply because of its known teratogenic potential. So rather not use it in the reproductive age group as much as possible. And if she has been using that molecule in the past due to its efficacy, it is advisable that you stop this drug. So preconception counseling is very important. Now, certain basic facts we should tell all our clients. One is that there is a baseline risk of congenital malformation. In fact, that is a pregnancy which has not had any exposure to any drug can never be guaranteed. The spontaneous abortion rate in confirmed early pregnancy is nearly 10 to 20%. And the risk of spontaneous major malformations is 2 to 3%. This is the baseline. So, if you explain this to the patient well in advance, during the preconception itself, that even if you don't take medication, chances are this much, then she makes a better decision to take your advice if you feel that the medication is important for giving her a good mental health. Screening is another area which can at times become very stressful. So, a lot of people say that don't screen, but then we know that patient, especially if she is on lithium and paroxetine, it is better that we ask for screening. And when you are advising screening, it is better to involve the entire family with the client, because especially in India, the family has a very important role in decision making. Now, this was a rough outline that I wanted to talk to you all about the basic changes. So I'll just take a 1-minute break to interact with you all. If you have any questions or anything regarding this part before we go on to individual disorders, because I think 40 minutes is quite a long time. So I'll just take a sip of water and give you a few seconds to think and discuss something if there's anything in your mind. To get the screen up.
I think if I'm allowed to speak.
Yeah.
Thank you, Sonia ma'am. It's going off pretty well. I think there are a few bit of questions and comments which we see in the chat box. So if you permit, can we take 1 or 2 of the questions now?
We can. I think that will give me a little bit of sipping time. And
yeah, sure.
Time. Nishant, if there's anything, please do take that question.
speaks about the fact that this is a group of people who need to be convinced most regarding need for medications in not the patient but the treating obs and gynae specialist. Yes, this is definitely one of the factors where we do need to have more dialogues and more interaction with our colleagues who are working with women in the childbearing age, or particularly during pregnancy or postpartum period. Dr. Paramveer also asked, like, what is the safest anti-epileptic? Is it lamotrigine? But if it is lamotrigine, it definitely, we all know that it needs slow titration, and particularly for a newly presenting epileptic patient who is pregnant, which medicine should be given to prevent a second seizure while lamotrigine dose is achieved. So this is one question. I think this is a very, very important question.
He has three questions. Wait, can I stop at it? One is, which is the
safest I'll simplify the question. I'll simplify the question. So he is asking, which is the safest anti-epileptic during pregnancy, particularly when a person when a pregnant lady comes to us with a seizure, and we take a call that we have to give lamotrigine. It takes time to build up. So what alternative we have so that we can prevent
other molecules that you have? So I'll go one by one so that I don't miss the question.
Yeah, sure.
I think you have two drugs which you can use more safely. One is lebrasitam and the other is oxcarbazepine. Of course, the efficacy of and which type of epilepsy is a crucial factor. But other two molecules which are relatively safer are lebrasitam and oxcarbazepine. As far as using a mood stabilizer, which is safer, yes, of late, lamotrigine is turning out to be a much safer molecule. Earlier reports that it is causing cleft palate and it is neurotoxic. But current research, no, when they studied the confounding variables, lamotrigine is safer. But then, lamotrigine not only have to build up, and there's so much of pharmacodynamic changes with this molecule. I will be discussing that in my further presentation, that lamotrigine, you have to, again, it gets cleared up very fast. You have to hike up the dose also a lot to get the required levels. And postpartum also, again, you have to, reduce very fast. So, but then it is efficacious for bipolar depression.
Absolutely.
It's not a very good anti-manic molecule. Most of the research is saying that lamotrigine does not have anti-manic propensity compared to, say, valproate or other medications. And that's why when we'll be discussing bipolar disorder, we'll be telling how SGAs are coming into the scene. But yes, lamotrigine is the safest. Other molecule that has been tried is oxcarbazepine. You can try that because it's safer than compared to carbazepine. Valproate and carbazepine, better to avoid during pregnancy. And what was the third question Paranjit had asked? I think, did I miss out something?
Madam, the next question is that would you like to give any molecule while you are building up lamotrigine so as to prevent the seizure attack to occur again while the person is pregnant? So what is your choice of molecule to do that?
See, I mean, if you're building up and you want a quick relief, say she's in a cluster attack, I think seeing that epilepsy is such a, what should I say, emergency, a cluster attack can be life-threatening. I would go in for adding lorazepam as a PRN because lorazepam is very short-acting and it controls seizures very quickly. It is one of the safest molecules. But rather, if you're doing it only for epilepsy, why take lamotrigine in the first place itself? Go in for lebrasitam or oxcarbazepine rather than having two drugs, because we know when you go for true polypharmacy, the chances of congenital malformations risk is going to be much higher. It is going to be higher, but it's a gray area. I would rather, in the first go itself, select a molecule which is more safer, like say lebrasitam or oxcarbazepine.
Ma'am, he further asked, how safe is etizolam? Like maybe your experience or
there are
what?
very less reports on etizolam. I mean, I must admit, there's very few studies especially on etizolam. The only that I have read mostly about the shorter acting drugs are safer, like say lorazepam, and maybe you can go up to alprazolam. But I'm not aware about etizolam. If there are, I think if anybody has more literature, they can share it with me. So can we go on to the next part?
Yes, ma'am. Please. Thank you. Thank you so much, ma'am. Please go ahead. Thank you.
one of the commonest mental disorders that we all deal, whether it's the Indian population or the Western, is the increasing incidence of perinatal depression. Nearly 10 to 12% of our women are depressed during their pregnancies. And most of them are, again, not diagnosed though. But then we need to identify, because like we had mentioned earlier, that depression can have serious implications if not identified and treated. In depression, the only drug that has received FDA warning, like I had mentioned, was paroxetine. Most of the SSRIs have been found to be safe. That is I will go more about the data on that in my later part of the presentation. This has got hanged. Let me see if my slides are getting a bit hanged. Yeah, slide. So what we have seen is that nearly 14 to 23% of our women, sorry, I'll just go on back. 14 to 23% and nearly about 22% of our women will develop PPD. And that means postpartum depression. Antenatal depression can continue into postpartum depression, and you can also develop in itself PPD. There's nearly 22% in the first 12 months after delivery. So antenatal depression, we are very, very particular about identifying early, because if not treated, it can lead to postnatal depression. And that's not because there's such a continuous depressive state, hypocortisolemic state to the fetus due to depression, which should be avoided. Now, the American Psychiatric Association and the SEOG recommend that if the depression is mild, try to use psychotherapy and avoid antidepressants unless it is moderate with the past history of a severe episode. And of course, many of our clients also request for non-pharmacological intervention. But in the Indian scenario, we were discussing that day that in moderate depression, if there is past history or there is family history of depression, it is better that we use antidepressant medication, because we don't have trained therapists mostly assisting us, and therapy takes much longer, and especially for our rural population, where there will not be an access even to a psychiatrist, forget about a CBT therapist. So maybe at moderate levels, you can consider using antidepressants. Many women, like I said, will significantly make a forceful appeal for therapy, and then you have to respect her sentiment and agree to do so. But in the West, nearly 70% of our women with depression are taking treatment with antidepressants. So people have got aware in the West that what is the impact of this disorder, and they make decisions that they are willing to take medication. So 70% of cases are being treated, even the mild to moderate group is being treated with antidepressants. Now coming on to the next part, that in severe depression, if a patient is already receiving antidepressants and there is a high risk of relapse, it is better that we use the same antidepressant rather than trying to change the drug just because of its safety profile. The efficacy should always be kept in mind. If you have had past response to a particular drug in a lady with severe depression, try to maintain her on the same depressant, because we can't have double exposure, meaning that we can't afford to have a relapse. That means if you have a relapse, the fetus is exposed to the depressive state. And if you're using a new molecule, you're not even sure whether it's going to act or not. So this double exposure can be very troublesome for us in our practice. So better to take the patient and the family into confidence about your decision of maintaining the same antidepressant. If initiating an antidepressant during pregnancy or for a woman considering pregnancy, previous response is a very important factor. But if this is the first episode and previously she has never been treated with any antidepressant, sertraline appears to be one of the safest molecules. And if you see the BARB guidelines or the Australian, sertraline is being preferred. But again, like I should say, efficacy should always be kept in mind. Don't just go always by these guidelines or the criteria, because there is so many factors which come into play. But yes, if you're using a drug for the first time, you're justified using sertraline because of its higher protein binding capacity and causing less exposure, placental passage. So, like I'd already mentioned, that if antidepressants or any other drugs have been used, go in for echocardiography, especially for paroxetine, and you can do it in the 18th week. And if the mother has used antidepressants, hospital delivery is always preferred. So you should mentally prepare the patient that she should try to reach the hospital in time so that she can be receiving a team effort by the pediatrician as well as the obstetrician. Now, when it comes to postpartum depression, there was a lot of controversy in DSM-4 and 5. Let me know that they said that an episode of depression occurring in the first 4 weeks is the one which is identified as postpartum depression. But research point of view, we are considering postpartum depression right up to 1 year. But in the first 4 weeks, usually postpartum presents in a more melancholic manner and requires a very proactive management with antidepressants. But we also know that in the postpartum depression, there are a lot of varied presentations, not only just melancholic depression, it can be bipolar depression also. Sometimes it becomes difficult to identify whether this is MDD or whether this is a part of bipolar depression. But yes, it is more melancholic and you have to give antidepressants. But if you have a slightest doubt that there is a family history of bipolarity and you're getting some mixed features and you've used the MDQ scale, I mean, differentiate bipolar depression with purely postpartum depression. And this is a very, very crucial part of depression because it's melancholic and it can lead to suicide, and we have to aggressively treat. And at times, if it is very severe, you might even, antidepressants sometimes are not enough. We are adding mood stabilizers and antipsychotics. So the first 3 days postpartum period, very close observation is required for postpartum depression to differentiate whether it is very infanticide also. So if you feel that the drug is not, am I audible?
Audible, ma'am, audible.
Okay, sorry, because this thing is showing no net. Okay, so if the depression is very severe, you can go for ECT. ECT is safe, but of course you need a whole team. You need your anesthetist to be there to guide you, and also preferably the obstetrician also to be there with you. And not an easy job in our rural areas, but yes, ECT can be considered and can be life-saving for our psychotic depressive clients. Now, coming on to antidepressants in pregnancy, if you look at TCAs and SSRIs, more and more Western data is on SSRIs. But previously, TCAs were the only drugs that were available. They cross through the placental barrier easily. They have been found to be efficacious, but nortriptyline and desipramine, technically, they are less anticholinergic and hypotensive than amitriptyline and imipramine. So you may prefer these two. But I know many of my seniors I remember in our training have used amitriptyline very successfully. It's a good molecule efficacy-wise as well. So maybe TCS can be used, but yes, they do increase the risk of preterm delivery, and use in the 3rd trimester can result in neonatal withdrawal, but this is short-lasting. There have been some reports of limb anomalies in the earlier studies, but later studies have not confirmed. So TCAs are also not as harmful as we had thought them to be. SSRIs, like I have already mentioned, that they are relatively safer and they have the least passage. But PPH, yes, the pulmonary hypertension is a point of a little bit of worry at times, and patients don't give consent once they know about this side effect. But again, this is quite a serious implication, but the risk is not as much as we have thought. There are some reports that paroxetine is more associated with PPHN, hence paroxetine should not be used. But sertraline also can lead to it, but the chances are the risk is much lesser. Then you can also have the patients who are the fetus which has been exposed in the entire pregnancy to all the 3 trimester to an SSRI, the chances of poor neonatal adaptation syndrome is also there, but more so if it has been used in the 3rd trimester. About 30% of the infants can have PNS, but again, this is not a life-threatening situation and it can be managed. A lot of controversy about, like I said, about persistent pulmonary hypertension, that its risk is about 1 to 2 per 1,000 live births. But the latest research has shown that the absolute risk is not very high. The risk difference is only 0.619 per 1,000 live births. So it's not as high as we had thought, but yes, we should be aware of it and patient parties should be informed. And I'll just skip this part about PNS because we know that it is resolves very easily. And but again, that's the reason for having a hospital admission.
Yes, ma'am. And I just to intercede, yeah, we have quite a few questions also in the chat box. So maybe we'll need 10 minutes for that.
Okay.
So yeah, thank you. Go ahead, ma'am.
How much time do we have left, Jyoti? Can I continue? Am I audible?
Ma'am, we can have maybe the presentation, then we can have question and answers. Yeah.
Okay. So many, people said that taper our SSRIs in the 3rd trimester because risk of PNS can be decreased. But then 3rd trimester, already the drug availability is lesser because the volume is much more of the plasma and the drug levels are lower. And risk of relapse unnecessarily will be introduced if you try to taper in the 3rd trimester. Because you can't afford to have a postpartum depression or an aggravation of the mental state in the postpartum period, because postpartum period is a very, very vulnerable time where the chances of relapse of all our disorders are higher, especially even if there's bipolarity is highest relapse occurring in the immediate first 3 days. Or if she's going into what is called postpartum psychosis, that also risk is much higher. So avoid tapering in the 3rd trimester just to avoid PNS. We decrease the dose. Not a very sensible idea, I think. But of course, we can have a discussion on that later. Breastfeeding should be promoted in a mother who is on SSRIs because it can decrease the withdrawal symptoms. Now, coming on to long-term development outcomes, this is again a very controversial area. SSRIs were implicated to cause autism. This was the most worrying part, which really kind of a red flag it became initially. But luckily for us, the current research has found that when you adjust for confounders, the risk of maternal depression, if it is considered, statistical significance is usually lost. That means SSRIs do not cause autism as much as it was thought of. But again, there are more than 7 studies which are meta-analytic studies. There is equivocal this thing. Some say, yes, it is an independent risk factor for autism. And other studies say, which have adjusted for confounders, they have found that no, we should avoid, it does not cause autism as much as it has thought to be. So again, we have to inform our clients, and there's a word of caution on autism. So I think, should I stop here? I have a lot of slides, but can we?
Ma'am, 5 more minutes, no problem.
Okay, okay. Now, coming on to basic guiding principles that regarding breastfeeding, also we have to keep some points in mind that SSRIs, they can dysregulate lactation, because that mothers taking SSRIs, they can experience a delayed secretory activation. So they need support during that time to achieve their breastfeeding goals. Sometimes you have to, de-stress them and encourage them to pump their breast a bit so that they can achieve lactation. So SSRIs do have technically this problem at times, not in all, but in few months. Now, a little bit of new research that has come on, I thought we would have put that in the discussion, but I would like to mention Allopregnol. This is the latest molecule being used successfully for postpartum depression, but then it has only to be used, it is contraindicated for bipolar depression. it is used exclusively in the postpartum period. Now, you see, we knew that there is a drop of estrogen and progesterone immediately in the postpartum period. But most treatments by using estrogen or progesterone was found to be not effective in treating depression during this time. But allopregnol, this is a unique molecule. It is a positive allosteric modulator of synaptic and extrasynaptic GABA A receptor. And it has been found its level decreases after childbirth. And if it is given in the form of brexanolone, which has been introduced in the West, not available in India as yet, IV infusion, 60-hour infusion. And it has been found to give us good results. So maybe this is something for us, all of us, to think about it, that, new research, understanding more about different types of postpartum depression. I think this is one area that is really intriguing, giving us more clues about the biological aspects of postpartum depression. And brexanolone, yes, is an interesting area, giving us clues to understand how postpartum depression evolves and how we can understand the pathology of depression. There is a lot of research going about probiotics as well, but of course there's no evidence as yet. This is just the early stage. And Jyoti in the morning was telling that we should cover anxiety also, but this topic is so vast. I would say anxiety is one of the most underdiagnosed disorders. There are no scales also to detect it properly during pregnancy, but it is very important to identify anxiety in the antenatal period because it is a crucial marker for postpartum depression. Anxiety should be addressed, should be treated, but how do you go about it? We know that benzodiazepines you cannot use. Most obstetricians use straight away benzodiazepines, but encouraging part is that SSRIs are safer. Go with low doses, gradually build it up, because we know that smaller doses are useful as anxiolytics, but at times you do need benzodiazepines, especially when patient is in a lot of panic. In that cases, you can use, like I had mentioned, lorazepam. But all the benzodiazepine side effects that have been mentioned earlier, like risk of oral clefts, pyloric stenosis, alimentary tract atresia, these are there theoretically. They're very, very low incidence. So if you see in the statistical analysis point of view, if you go, it is so rare that shorter acting ones. And of course, avoid them in the third trimester. Don't use heavy doses because, you can have this floppy baby syndrome. And also benzodiazepines high dosage usage has been found to be associated with increased risk of cesarean delivery requiring ventilatory support and preterm delivery. Now, I'll just mention quickly about bipolar disorder, that yes, a lot of relapse rate is high in the postpartum period. We have to address it. The controversy is whether we should use lithium or we should go in for SGAs. Lithium now, more and more reports are saying it is safer. Epstein's anomaly risk is much lesser. So you can use it. You can go through NICE guidelines. They say that you can use lithium, but monitor it every 4 weeks, up to 36 weeks, and then weekly. And like I'd already mentioned, that you need to adjust the doses in the antenatal period and the postnatal period. Of course, valproate, avoid as much, don't take it, I would say. And regarding folic acid supplementation, if it is used prior to conception, that is in the preconception, only then it is more useful. You have to go for higher doses up to 5 milligram and at least continue it till the end of the third trimester. Valproate, of course, like I'd already mentioned, it is a teratogen. I'll not go into what are the side effects, and because we lack of time, but we all know that neural tube defects, the risk is very much higher. Now, the latest, of course, we are using a lot of SGAs, but we know that there is increased risk of gestational diabetes, especially with olanzapine and quetiapine. And you can have large for gestational babies, so you have to continuously monitor. With aripiprazole, of course, there is no risk of gestational diabetes, but database is quite low for aripiprazole. I think we had heard Dr. Jayashree Kulkarni in Australia, they have been using aripiprazole more, and it seems to be efficacious, but too early to say. But olanzapine, yes. Quetiapine, yes. These are molecules which are useful because they have mood stabilizing effects, and they may be preferred to mood stabilizers. Again, we can have a discussion on it later. Clozapine, data says you can use it in pregnancy because in severe refractory cases, In life-threatening cases, you can use clozapine, but monitor, but don't use it in for breastfeeding. Again, we had discussed lamotrigine. It's a very volatile molecule, much safer, more efficacious in bipolar depression. You need to adjust because there's so much of potential increase of dose increase required in the antenatal period, and then the level drops immediately after the postpartum period. So you need a lot of monitoring of this molecule. But yes, it is much safer than the other mood stabilizers. Now, lastly, just quickly, I will go on to just briefly touch that if a lady has schizophrenia and she decides to become pregnant and she's struggling with her fertility, you can use a prolactin sparing agent. And we know that severe psychosis, what are the risks involved? So stopping medication is not very sensible. And psychosis during antenatal period of any kind does predict postpartum psychosis as well. So do treat. Medications are very, very important in this time. And of course, you can use the safer molecules like we had discussed. And most of our antipsychotics are safe, which we had already discussed. And there's huge database on haloperidol in the past. It is safe and you can use it. But now we are preferring more and more of SGS because of its safety profile. But then we also know that I think in the coming years, we'll have more data that the metabolic syndromes, which have so significantly increased with olanzapine and clozapine and quetiapine, that we may have a comparative data very soon whether FGA is safer or SGA is safer. Depots, yes, you can try, but to avoid it as much as possible. But if there is poor compliance, depot may be used. And we all should be aware that depots, what are the problems along with it. So you sensitize your obstetrician also about it. In case she develops EPS, you'll have to manage it. And that's at times becomes challenging. Now, in the postpartum period, risk I had already mentioned, very high risk of postpartum psychosis, especially in the first 3 months, first 3 days, very crucial because of the dropping levels of estrogen and the antidopaminergic activity. The loss of estrogen, antidopaminergic activity may increase the risk of further decompensation. And a worsening of the mother's state can have significant impact on the child's cognitive and behavioral development. So to sum up, let's just have a quick look at this slide, which I'd already discussed, that with FGAs, you can have neonatal dyskinesias at times. With phenothiazines, you have risk of jaundice. But then preterm birth and low birth weight, it is there, but it is very minimal, like birth weight, hardly 175 grams lesser. So, if you look at it from a statistical point of view, they say significant, but then the number of days and the amount of birth weight, it's not so significant as it is implicated. And they are not major teratogens. This is the good part. I mean, the latest 2016 study has compared more than 9,000 pregnant mothers on SGS, and they found that they are not major teratogens. So they can be used safely, and even clozapine can be. And like I already had mentioned, quetiapine has the least placental passage, hence it's quite safe. And aripiprazole does not have the other side effects. And none of these molecules are associated with any risk of congenital malformations. So that's the best part of our. So to end up, every baby deserves a healthy mother, and mental illness and or with medications used to treat them may each pose a risk on its own to the mother and the child. And no single study can tell the whole story. We need to keep a balanced view of the risk and benefit and give this view to our clients in a simplified manner. And the relative importance of various risk patient. So individualization of the treatment is so very important. And lastly, the most important part, trust and a good working relationship between the client and the clinician is so critical in decision-making when you're prescribing in the perinatal period.
Thank you, ma'am. Thank you for a very lucid presentation. And I'm sure we all would agree that this is such a vast topic, and trying to cover the more important aspects of it in 45 minutes is a huge and mammoth task. So with the permission of my chair and the organizers, I'm sure madam has answered most of the questions which have already been put forth over here. So I'll ask some interesting questions with the permission of the chair and the organizers. So ma'am, one question is that Dr. Ranjan Bhattacharya is asking that it's a very interesting question. Which SSRI when used in the 3rd trimester has the highest risk of persistent pulmonary hypertension in the newborn? Again, this is something.
Paroxetine. It's paroxetine, which I had already mentioned. No, paroxetine
Yes,
in the third trimester should be avoided.
Okay. Thank you.
Sorry. So, ma'am, can you stop this slides share, please?
Slides. Yeah, I'll just stop.
Yes, thank you. Sorry. It's just that people might want to see the speaker.
Yeah, sure.
Yes. So another question which I found very interesting is someone is asking, Dr. Human is asking about your experience, or maybe what about using long-acting olanzapine in symptomatic schizophrenia patients during pregnancy. So maybe take off my chair or the speaker. Ma'am.
GTT, no, like olanzapine, we know we have to go in for regular glucose oral GTT test. If you give a depot and by chance she goes into hyperglycemic state, that can be very troublesome to manage. For to use a long-acting olanzapine, unless the compliance is very poor, and you know that she has a past history of episodes are very severe, depot in general should be avoided as much as possible. And hyperglycemic states with olanzapine, we have to be aware of it. You know, if she goes into diabetic ketoacidosis, she will require hospitalization. So I'm not very comfortable with the idea of using a depot olanzapine. But do you use it if you feel compliance is poor?
Right, ma'am. So another very interesting question which appears in the chat box is from Dr. Shazia. She asked that if the patient agrees for contraception use to prevent pregnancy while taking psychotropics, what is the safest one you would recommend? So, yeah.
You know, she doesn't want to conceive, go for copper T rather than going for OC.
No, the antipsychotic, the psychotropic she's asking, which psychotropic is the safest while using maybe oral contraceptives?
You go with this most efficacious molecule. I don't think that should be the criteria. Efficacious molecule should be the criteria, which drug she's responded to rather than the drug itself. It's important to keep in mind that you're going to use a molecule which is responded to.
Thank you.
Barrier methods are, what she was asking the first part, that barrier methods are better because the hormonal milieu is already changing. And then when you introduce OCPs again, we know that the reproductive hormones, they do have a role to play. We are yet researching onto that. And that can again, be one more big factor. So try to avoid OC pills.
Ma'am, another question is how safe is using propranolol for reducing anxiety during pregnancy?
Propranolol should be avoided.
Avoided, yeah, that's what.
Because it is... I have not ever seen when you have so many other molecules for using anxiety. You have better results with pregabalin. Now you have gabapentin, you have short-acting benzodiazepine, or in fact low-dose TCA also. Why go for propranolol?
Another question from Mr. Imran Ali. He asked role of IV ketamine for depression in pregnancy. Is there any role, or maybe is there any literature on that, ma'am?
IV ketamine, there's very little literature, though we all have started using in suicidal patients otherwise, but I don't have data on pregnancy on it. So anybody else, Dr. Ranjan or anybody else share with me? I wish Dr. Andrade was there. He would have just jumped on to me and given me the information right away. IV ketamine in pregnancy, I'm not aware. I have not tried to use. In fact, Nishant, we wanted you to speak on RTMS because I have, with consent of my patients, used RTMS once in a while. So I'm not an expert in it. But you could, in fact, highlight to us on RTMS in pregnancy.
Yes, ma'am. Definitely. I think this question was asked by Dr. Jyoti ma'am also. Yeah. So basically, we have recently published a review article on use of neuromodulation as a whole that includes RTMS also in the Journal of Indian Association of Private Psychiatry. As well as there's a IABP guideline thing is going on where we have contributed this chapter. So briefly speaking, yes, definitely there's a lot of literature which talks about the efficacy and safety of neuromodulation, particularly RTMS and TDCS in pregnancy. And they have found that number one, it is a safe method of treatment, definitely a safe method of treatment. Now coming to the efficacy, yes, as with other conditions, we do have decent evidence for its efficacy in depression, but not in other conditions, including anxiety spectrum disorders or for schizophrenia for that matter. So we do not have that. And as you have already mentioned in your presentation, ECT is still one of the safest measures if you are actually getting a suicidal patient or very severe psychosis, or maybe perinatal psychosis, or maybe postpartum psychosis. ECT is still the benchmark or the gold standard treatment, which we also found in our systematic review also. So this is, in nutshell, which basically I can talk about it, ma'am. So yeah, Jyoti ma'am, over to you if you have anything to add to this.
I think I just saw Dr. Rukshada had replied about propranolol use for anxiety and migraine and blood pressure. And even I have read that, we can use it, though we are of course not using it very frequently. Apart from that, I think there was another question by Dr. Imran Ali on what is the effect of mother's mental illness, particularly depression, on the intrauterine fetus. That I think ma'am has already covered. Yes, she's already covered it in one of the slides. Yes. On the effect on the fetus.
I think most of the questions I am skipping because they have already been covered.
They have already been covered, yeah. Yes. I think most of it has been covered. How safe is tofisopam? I think Dr. Paramveer Khera had asked. Ma'am, would you want to answer? Because I think we do not use tofisopam. It's category D, I think. Yeah, it's category D. I don't know whether we don't use it anyway. So apart from that,
think, as far as I just forgot to mention, I think we all should be giving to our patients when they have these doubts, especially for breastfeeding and all. You can give this Lacmed. I didn't discuss intentionally, didn't touch on it because of the vastness of the topic. Lacmed is easily accessible. Otis, the sites which give information to your clients, but again, our rural population, it is we who have to explain nicely. They are not so savvy to, but urban class, yes, you can give them those sites because the labeling part of the drug, it's more important rather than this FDA, ABCD. It has so many drawbacks. I think we can have a separate class on that later. And I have to, before, I will request both the chairs, before Arnanshu gets onto my neck, I have been postponing his dinner time more and more. And he's been hinting from behind how more you guys are going to discuss. I would request.
I think we have already, ma'am, we have already overshot our
I think we have covered most of
everything.
Yes. So, and thank you very much, ma'am. It was a wonderful, lucid presentation.
My pleasure.
And it was extensive. Yeah, we do need another class.
I think I needed some more people also to, many more experts who are much more. I missed Bhaskar, I missed Malay, and these kind of experts who could speak much better than me, I think. Though I am the chair in IPS maybe, but there's so much more to learn. I realized when I was reading that, my God, there are books and books and books. Bhaskar has sent me some 8 to 10 books. And I think the whole year I will need to understand them and read them. I really missed some experts in this area. And of course, Professor Prabha, who has always been motivating me to, coming up and reading and conducting workshops and training the obstetricians, training the health workers, and working at all levels. But of course, interacting with you guys is the most challenging, because I realized myself that there is so much still that I myself don't know. The more you read literature, go by in the last 5 years, there is so much advancement in this field that I think I am quite ignorant in many of those aspects. And maybe Rukshida can highlight those topics so we can have future CMEs with more experts.
Good evening, Dr. Abdul Majid.
So with the chair's permission, can we call the session a close?
Thank you.
Yeah. Over to you, Rukshida. Over to you.
Any last comments from both the chairs and the speaker?
No, I think that's it. Thank you.
I would just say thank you all for bearing with me.
Thank you.
Like Majid is saying.
Thank you, ma'am. Thank you. Thank you, ma'am.
Thank you for bearing with me. Thank you.
So thank you so much. But just a quick vote of thanks from my very able Joint Secretary of the Indian Association of Biological Psychiatry, Dr. Majid. If you could thank all of us, give her the vote of thanks and bring the session to a close.
Really, it's worth thanking particularly our speaker, Sonia ma'am, and whenever we listen to him, be it any conference for that matter across India, it's always heartening to learn from her. She has a wealth of knowledge, and the way she puts it, she is an ideal teacher for postgraduate students. And I will still consider myself as a student till I'm a psychiatrist in this world, and I would be a student always of teachers like of her caliber. So it has been a wonderful, lucid presentation, and I would like to thank you, ma'am, Sonia ma'am, for a wonderful lecture, and we wish and we hope that you would have a couple of more sessions on this section, in this section particularly, which is much needed by our residents, even psychiatrists who are in practice. So it has a lot of clinical implications, and I would say that, as you said rightly, that it's least discussed, and most importantly, the females who are conceiving, they stop it. And I would there are gynecologists actually who really threaten the patients that if you continue taking antidepressants, even like sertraline or antipsychotics, which are much needed, that you will lose your child will be abnormal. I think the debate should go beyond psychiatrists into the other specialties, particularly gynecology, that these are not so threatening as you think. They are as safe as any other drug from other specialties. Thank you, Dr. Jyoti, and Dr. Nishant, my dear friend from CIT Ranchi. Dr. Ruksheda, of course, thank you very much. So you said that thank us, so I'm thanking you as well. And thank you, IABP team headed by Dr. UC Garg sir, and we have Dr. Pramod Kumar, our Vice President. Alim Bhai is our editor, and there are many people. Prasanjit is our treasurer, and Dr. Bridji Prasad Rao is the CME coordinator. Thank you, everybody, and thank you, I think the Torrent Pharma, who have been helping us, Elcam Pharma, for supporting us this event. And we'll be back again in the first Friday CME next month, and the title or the topic of the presentations would be communicated in due course of time. Thank you all, and the participants especially who asked lovely questions and have made this event an interactive one. Thank you all.
Thank you, Rukshida. Thank you all.